Hello and welcome to Practical ECG courses. My name is Obaid. I am an emergency physician working in the UK. I enjoy teaching ECGs and I have been doing that for around 8 years now. My real passion is not just teaching ECGs, but teaching a concept-based approach to ECGs and how we can use these concepts in our day-to-day clinical practice. When I talk about concept-based approach to ECGs and deductive analysis, people are often confused and they ask me what that means and how it is relevant to them. So the idea behind making this video is to introduce you to concept-based approach to ECGs and to show you how it can change your practice. In the ED, ECG interpretation is usually done by using pattern recognition. Let me show you an example. Take a look at this ECG. If you have had some experience with ECGs, you can immediately diagnose ECGs like this one. The moment you looked at it, you instantly knew that it was an anterior wall MI. You did not have to think about it. This is because you are familiar with the pattern. And what happens when you see a pattern you are not familiar with? Will you be able to diagnose it? This is where deductive analysis comes into play. Deductive analysis is the next step of ECG interpretation, where you actively analyze what you see on the ECG and try to understand what's happening in the patient's heart. This method of ECG interpretation is not dependent on pattern recognition. To use deductive analysis to interpret ECGs, you need two things. First is the knowledge of some basic concepts, and secondly, you need to know how to apply these concepts to aid your interpretation. The main advantage is that you can now understand what is happening in the heart in almost any ECG, irrespective of whether the ECG is diagnostic or not. It might be easier to show you an actual example of how deductive analysis works. Pause the video for a second, have a look at the ECG, come to a conclusion, and then watch the rest of the video. My aim here is to show you how you can interpret this ECG even if you're not familiar with the pattern. I hope you've reached a diagnosis, and if you have not, good, because it gives us an opportunity to practice deductive analysis. Always do a proper systematic approach to ECG interpretation. For sake of saving time, I'm going to quickly go through the ECG and just focus on only what is abnormal in this ECG. So if you look at the ECG, the heart rate is somewhere around 75. The axis is normal. It is sinus rhythm. The P waves are normal, both in lead 2 and in V1. The PR interval also seems to be fine. There's no significant changes anywhere. The QRS, if you look at the Q, you can see there's a lot of Q waves in this ECG. And you can see that the Q waves is more than 2 millimeters deep, which tells you that it is pathological Q wave. So you have now one abnormal finding. And then coming to the R wave, you can see that the R wave is actually tall. If you measure the R wave here, it is 22 milliseconds, sorry, 24 milliseconds, sorry, 24 millimeters. Apologies. And if you look at the S wave amplitude here, it is 12 millimeters. So that comes to a total of 36 millimeters, which confirms that we do indeed have tall R waves and we actually have an LVH. But forget the LVH, we just needed to confirm that we did actually have tall R waves. Now we have identified two pathologies, tall R waves and deep Q waves. What else? S waves look normal. It's present in lead 1 and then all the way from 1 to V1 to V5. What else? The T waves look normal. There's no abnormalities, no T wave inversion, no tall T, no biphasic T. The U wave looks normal. You can see it in the precordial leads. And the QT is also normal because you can see it is less than half of the RR interval, which is the rule of thumb that you follow for QT interval. And is there any special deflections like a delta wave or an epsilon or an R wave? Sorry, Osborne wave? No. So you don't have any of those special waves as well. So in short, to summarize, you have a sinus rhythm with a normal axis but with pathologically deep Q waves and tall R waves. So how do you interpret this information? Let's quickly review a couple of basic concepts. I'm sure you're all familiar with the information in this slide. This is the first thing you're taught when you learn ECGs. Now, what is generally not taught is how this information is relevant to us in clinical practice. A couple of things that I would like to re-emphasize. Remember that an ECG is a recording of the electrical activity, and an ECG paper is basically a graph paper on which you plot a time on the x-axis and voltage on the y-axis. So essentially an ECG is a graph of time versus voltage. What is this time that we are talking about? It is the time taken for conduction across some part of the heart. So if you're talking about QRS, then the x-axis of the QRS, which is the width of the QRS, will tell you about the time taken for the electrical impulse to conduct across the ventricles. Now think about what happens in an LBBB. In LBBB, the left bundle branch is blocked and therefore impulses can't go down to the left side. And because it can't go down to the left side, the left ventricle depolarization gets delayed. The right ventricle gets depolarized first, and then the impulses travel across to the left ventricle. Now, what is the impact of this? What happens is now the time taken for the ventricular depolarization is increased. And how would this be reflected on an ECG? It would be reflected as an increase in width of the QRS. So the first and the most important criteria for the diagnosis of an LBBB is a wide QRS. The same principle is also applicable for an RBBB. So if you want to diagnose any bundle branch block, be it right bundle branch or left bundle branch, the first criteria that you must be aware of is that the QRS is wide. Now, when most people are asked the criteria for either LBBB or RBBB, they often start with the morphological criteria like RSR or the rabbit ear in RBBB. This is not correct because you can have RSR or the rabbit ear morphology even in patients without RBBB, but you cannot have RBBB without a wide QRS. This is one of the advantages of concept-based approach. Once you understand the concepts, you will not need to learn things by heart. You can simply derive them when needed. I'm digressing. Let's go back to the original point. The point that I wanted to convey is that the width of any deflection or interval on the ECG tells you about the time taken for the electrical impulses to conduct across it. So when there is more time taken for the conduction, the deflection or interval becomes wider, like in the LBBB. Now another example is AV blocks. In AV blocks, the AV node is deceased and therefore conduction across the AV node takes more time. And how is this manifested on the ECG? By a prolongation of the PR interval. Now the reverse is also true. When less time is taken for conduction, the deflection or the interval becomes narrower. Example, in WPW, the PR interval becomes shorter. Why? Because the accessory pathway permits the electrical impulses to reach the ventricles earlier than usual, and so the ventricular depolarization occurs earlier. So far we were talking about the implications of x-axis, that is time, or rather the implications of changes in the x-axis, that is time. Now let's consider voltage or the y-axis. This is much more simpler to understand compared to the time or the x-axis. Now when there are changes in voltage, the amplitude of the deflection gets changed on the ECG. When the voltage increases, the amplitude of the deflection increases on the ECG. And when the voltage decreases, the amplitude of the deflection decreases on the ECG. Now, what causes the voltage to increase or decrease? Before we discuss that, there is a simple concept about vectors which we all should know. In physics, vector is anything that has magnitude and direction. As the waves of depolarization traveling across the myocardium also has both magnitude and direction, depolarization can also be referred to as a vector. So what is the effect of direction of a vector on an ECG lead? Each lead can be considered to be an eye looking for vectors. If the ECG lead sees the vector as traveling towards it, it documents a positive deflection. And if the ECG lead sees the vector as traveling away from it, it documents a negative deflection. Now, this is a very simple but a very important concept which is critical in interpreting ECGs. I'm sure you're all familiar with this diagram. You have the SN node, the AV node, the bundle of His, the bundle branches, and the Purkinje fibers. In addition, you have the epicardium, the myocardium, and the endocardium. What I want you to focus on is the location of the bundle branches. The bundle branches are located in the subendocardial region. This is a very important bit of information. This is because the Purkinje fibers arising from the bundle branches travels from the endocardial region all the way through the myocardium into the epicardium. What this means is that every time an impulse travels down from the bundle of His into the bundle branches, it causes the ventricle to depolarize from the endocardium to the epicardium in this direction. So the ventricular depolarization vector travels from the endocardium to the epicardium. Now remember that we have leads around the heart. This is V5 and this is V6. Remember, there is also V1, V2, V3, V4, and V5 and V6. We don't need that for now, so leave it at that. So what does V6 see? It sees a vector as traveling from endocardium to the epicardium. And how does the V6 lead document this on the ECG? Based on the concept we just learned before, any lead, when it sees a vector as traveling towards it, it documents a positive deflection. So V6 and V5 documents a positive R wave on the ECG. Now suppose you have a thickening of the left ventricle, as in a left ventricular hypertrophy. What happens to the vectors now? It becomes significantly increased in amplitude because the vectors have to now travel through the increased thickness from the endocardium into the epicardium. And how is this deflection like inscribed on the ECG? Because there is an increased thickness of the ventricular muscle wall, myocardial wall, there is more depolarization, more current, and therefore more voltage. On the ECG, this is documented as a tall amplitude of the R waves. So whenever you see a tall R wave in V5 and V6, you need to consider the possibility of an LVH. That is the first learning point. Now, you can also apply the same principle on the right side as well. Suppose V1 sees a very tall R wave. What does that mean? It means that the right ventricular vector is also increased. And why is that? Because of RVH. Why RVH? Because V1 is the only lead which looks directly at the right ventricle. So learning point here once again, tall R wave in V1 is indicative of RVH and in V5 and V6 is indicative of LVH. I hope that's simple enough. Another important thing to remember is that there is a chest wall between the heart and the lead. So chest wall changes can also affect voltages. For example, in patients with a thin chest wall, you can have high voltages on the ECG even without an LVH. This is especially true in children and young adults, which is why LVH is usually not diagnosed in patients below 40 years of age. The Sokolov-Lyon criteria for LVH, the one that we used earlier, where you add the sum of the R wave in V5 over V6 with the amplitude of the S wave in V1 being more than 35. So the Sokolov-Lyon criteria is not applicable under 40 years of age. This is something that is not commonly known. LVH should not be diagnosed in patients under 40 years of age based on the ECG. Okay, now we have covered most of the concepts we need to make a diagnosis for our ECG. But since we have come so far, let me spend another couple of minutes and explain something else. If you have found this useful so far, you will definitely find the next bit useful as well. Now that we have discussed the high voltages, let's consider the low voltages. Suppose you have an ECG with low voltages. What are the possible causes? You don't have to rack your brains anymore because you can now derive it by applying the concepts that you already know. Our first impulse to answer this question might be to say decrease thickness like in atrophy, but then you can't actually have an atrophy of the heart, can you? Well, you can. Like in cancer, you can have cardiac atrophy because of both the muscle wasting of cancer itself as well as some of the anti-cancer treatments. But we are not too bothered about it because it is not too relevant to us in the ED. So what are the causes of low voltages on ECG which is relevant to us in the ED? There are a lot of causes for low voltages. Let's look at it one by one. You can start from either the lead and then move towards the myocardium, or you can start from the myocardium and then go towards the lead. As I said earlier, don't forget that there is a chest wall between the myocardium and the lead. So let's start with the chest wall. Suppose you have a chest wall which is very thick, like in a patient who is very obese. There's a lot of fatty tissue around the heart, and this results in a dampening of vectors being picked up by the lead. And so the magnitude of the vectors will be smaller than it actually is. And so the patient will have low voltages on ECG. So obesity is one cause. Now, once you take away the chest wall, the next thing you see is the lung. So in the pleural cavity, if you have a lot of air, as in a pneumothorax, or a lot of fluid, as in a pleural effusion, these can also cause dampening of the vectors. So, another cause is pneumothorax or pleural effusion. Both are causes. Now, once you take away the pleura, then what you have is the lung. If you have too much of air in the lung, as in emphysema, again, that causes low voltage on ECG. Once you have taken away the lung as well, including the pleura, the next thing that you're going to see is the pericardium. So, you can have pericardial effusion. A large pericardial effusion can again cause dampening of the vectors and produce low voltage on ECG. So these are all causes outside the myocardium which decreases the voltages by dampening the signals coming from the heart. Now that we have reached the myocardium proper, suppose a patient has had an MI and this area is completely infarcted. What happens to the vectors there? The infarcted area cannot transmit any impulses, so therefore there is no vectors there. So what happens to the size of the vector there? It is actually smaller compared to the other side. So myocardial infarction is another cause of low voltages. In addition, suppose a patient has an infiltrative disease such as amyloidosis or sarcoidosis or hemochromatosis. Again, these can all cause small vectors for the same reason as what we have seen earlier. See, the size of the vector is decreased. Again here it is decreased. Again here it is decreased. So any infiltrative disease like amyloidosis, sarcoidosis or hemochromatosis, they can all produce low voltages using the same principles. Patients with myxedema can also have a similar myxedematous infiltration of the myocardium. Again, the same reason, small vectors and therefore low voltage on ECG. Patients with some of the cardiomyopathies like dilated cardiomyopathy, DCM, can also have diffuse myocardial fibrosis. And again, smaller vectors and therefore lower voltages on ECGs. So to summarize, low voltages can be caused by many problems anywhere, either in the myocardium or outside the myocardium. Within the myocardium, it's usually because of the loss of viable myocardium, causing smaller vectors like in MI, like in the infiltrative diseases like amyloidosis, sarcoidosis, hemochromatosis, myxedema, DCM. Essentially, the principle is the same. And outside the myocardium, again, you can have causes which causes a dampening of the signals, like pericardial effusion, emphysema, pleural effusion, pneumothorax, and obesity. And with that, you should now be able to derive all the significant causes of low voltages without needing any mnemonics. Coming back to our original ECG, now let's see if we can use the concepts that we have just discussed to analyze this ECG. Our initial interpretation was that there are two abnormalities, tall R waves and deep Q waves. If you look at the ECG, both the tall R waves and the deep Q waves are most prominently seen in V5 and V6. Based on the discussion so far, we know that whenever we see a tall R wave in V5 and V6, we should consider the possibility of an LVH. Now, that's one part of the mystery solved. But still, there are two more problems remaining. The first is that we still do not know what is causing the LVH. Is it hypertension or aortic stenosis or something else? And more importantly, how do you explain the deep Q waves in V5 and V6? The reason why this is important is because normally LVH is associated with small or absent Q waves. It is a lesser known facet of LVH, but LVH, as it gets worsened, the Q wave keeps becoming smaller, and then disappears. But in this ECG, you can see that the Q waves are disproportionately large compared to the LVH that you are expecting to see in this patient. So how can you explain the disproportionate size of the deep Q waves with that of the LVH? Now think about what deep Q waves represent. Going back to the concepts, when we have a deep Q wave, when we say deep Q wave, what we mean is that the Q wave has increased in magnitude. And when Q wave has increased in magnitude, what does that tell you? Q wave represents septal depolarization. So something's happened to the septum. What has happened to the septum? Because the magnitude is increased, that tells you that there is a septal thickening. Not only is there a septal thickening, there is a septal thickening which is disproportionate to the thickening of the left ventricle. What I mean to say is that based on this ECG, you know that both the left ventricle and the septum both are thickened, but the septum is much more thickened as compared to the left ventricle. In short, there is an asymmetrical septal hypertrophy. Take a look at this normal ECG. Here you can see that the thickness of the left ventricle and the thickness of the interventricular septum is more or less the same. Now look at this ECG. Here you can see that there is an hypertrophy of the left ventricular free wall, and there is also a hypertrophy of the septum, but the septum is asymmetrically hypertrophied. This is the condition referred to as asymmetrical septal hypertrophy, and this is the conclusion that we came to from the ECG previously. Now that you know that the patient has an asymmetrical septal hypertrophy, let's go back to clinical medicine. What is the diagnosis? Which condition is associated with asymmetrical septal hypertrophy? It is HCM, hypertrophic cardiomyopathy. It is actually written right there. And so the diagnosis for the ECG is hypertrophic cardiomyopathy, which is the number one cause of sudden cardiac death in young people. So, whenever you see a patient with syncope, especially a young patient with syncope in the ED, always look for HCM. This ECG is quite good because it has the signs of both LVH as well as deep, narrow, dagger-like Q waves of HCM. Now, a pro tip for advanced ECG learners watching this video. Some of the patients with HCM also have a concomitant WPW as well. As per one study, up to 33% of HCM patients also have WPW as well. It has something to do with both the conditions having the same genetic mutation. So the relevance for us in the ED is that when you diagnose HCM, always look for signs of WPW. That is short PR, delta wave, and white QRS. Now one last point before we wind up today's session. This patient has deep pathological Q waves. Why can't it be an old MI? There are two important differential diagnoses when you have pathological Q waves. The first and the more common one is MI. The second one is HCM. So how do you distinguish between the two based on the Q wave alone? Both are deep, so amplitudes are not particularly helpful. But what about the width of the Q wave? When you have ischemia, the myocardium does not conduct well, and as a result, it takes more time for impulses to travel through the ischemic tissue. And so, what happens to the Q wave? It gets wider. In comparison, what happens to the conduction in HCM? There is no delay in conduction, so the width of the Q wave is narrow in HCM. In fact, this is why the Q waves of HCM are called dagger Q waves, because it is narrow and deep. So the point of differentiation between the Q waves of MI and HCM is the width. If the width is 40 milliseconds or more, it is suggestive of myocardial infarction. If it is less than 40 milliseconds, it is suggestive of HCM. Once again, an understanding of concepts saves the day. Let's have a quick recap of what we learned so far. Even though we discussed only one ECG, we have actually covered a lot of stuff today. First and foremost, we covered how an understanding of the concepts of time versus voltage can be used to analyze ECGs. Whenever there is a change in the rate of conduction, it is reflected by a change in the width of the deflection or the interval. And whenever there is a change in the magnitude of the vector, it is reflected by a change in the amplitude of the deflection. We use this principle to determine how the first and the most important criteria of any bundle branch block is a white QRS, be it an RBBB or an LBBB. We also looked at how the amplitudes of R wave can be used to determine what is going on in the heart. When the amplitudes are increased, consider LVH or a thin chest wall. Don't diagnose LVH in a patient less than 40 years of age. When the amplitudes are decreased, consider causes from one side of the heart to the other. If you start from the heart, consider the causes affecting the myocardium, like MI, causes of infiltration, like amyloidosis, sarcoidosis, hemochromatosis, myxedema, TCM. All these can cause low voltages. And then consider the conditions which dampens the signal outside the myocardium, like pericardial effusion, pleural effusion, pneumothorax, emphysema, obesity, etc. Then we also discuss the condition where you can get LVH with disproportionately deep Q waves. Remember, LVH is usually associated with small or absent Q waves. We discussed the ECG findings of HCM. Rather, we analyzed the ECG and came to a diagnosis of HCM. We have also learned how to distinguish between the Q waves of MI from the deep and narrow dagger Q waves of HCM using the width. Less than 40 milliseconds is suggestive of HCM. More than or equal to 40 milliseconds is suggestive of MI. And the best part is, we did all this by building upon a few concepts. This is the concept-based ECG teaching that I have been talking about for years now. This is what I mean by simplifying concepts and practicalizing it for use in AT. Once you start understanding the concepts behind ECGs and start using them to analyze ECGs, then you are interpreting ECGs at a completely different level. When you use pattern recognition only to interpret ECGs, you see all the ECGs in terms of diagnosis because you know some diagnostic patterns and their criteria, and you are trying to fit the patterns in the ECG into one of those boxes of diagnosis. So when you have a pattern you are familiar with, you're fine. But when you have a pattern that you are not familiar with, then you struggle to interpret the ECG accurately and the ECG becomes non-diagnostic. Remember, most of the ECGs that we routinely see in the ED are non-diagnostic. But if you practice deductive analysis, you can analyze any ECG, be it diagnostic or non-diagnostic, whether you're familiar with the pattern or not. Even if it is a complex ECG, you can still glean some information from it, rather than simply diagnosing the ECG as a .g ECG. Once you understand the concepts, you stop thinking in terms of diagnosis and everything automatically starts linking together in your head, because the concepts are mostly the same. You will understand this, what I mean, as we do more and more concept-based sessions. As you can see, the only disadvantage of concept-based ECG teaching is that it takes time. Explaining concepts takes time and you can't rush it. Look at this session itself. It's already around 30 minutes just to explain one ECG. If I had to teach HCM ECG using only pattern recognition, it would have taken me less than 5 minutes in total. Even though it took me 30 minutes to explain one ECG, because I use concept-based approach to teach it, I could cover a lot of related but important points from different topics. The main reason why I did this session is because when I talk about concept-based approach, most people have no idea what I'm talking about, and they think it is some very advanced stuff being discussed which is not relevant in the ED. On the contrary, what we are doing here is actually delving into the basics and then laying foundation for expert level ECG interpretation skills. This style of ECG interpretation gives you a level of confidence like no other because you then know the topic inside out. If you like the concept-based approach to ECG interpretation and you would like to learn more about it, you are welcome to attend the Practical ECG series, which is a free online ECG teaching series which I conduct for senior A&E doctors. I conduct sessions roughly around every 2 months. The teaching in these ECG sessions are actually aimed at a level of interpretation expected from an consultant in A&E. That is to say, the aim is to teach expert level ECG interpretation, not just basic stuff. Every session, I discuss one topic, starting from the basic concepts and then go into the nuances of complex ECGs. In about 8 to 10 sessions, I'll cover almost all the important topics of ECG interpretation. As of now, we have completed almost half of the topics. To know more about the Practical ECG series, including the topics and the dates of the upcoming sessions, please check out my official website at www.practicalecgcourses.com. The website will also give you an idea of who I am and what I'm trying to achieve. If you're interested in attending the Practical ECG series, fill up the form on this link and you will be on my mailing list. I'll leave both the links in the description box as well. Thank you so much for listening to the session. Let me know what you think about concept-based ECG teaching in the comment box below. If you found this video useful, please like it and consider subscribing to my channel. Also share the video with your friends and colleagues. Have a nice day. Bye bye for now.